All right, is the audio okay? Great. So I'm Dr. Cortez. I'm a honorary member of the headache division here at the university and head the autonomic neurology clinic and laboratory. And that'll be the highlight of what we'll talk about today is what headache has to do with the autonomic nervous system and how they overlap. Thank you for those who are joining us online as well, and for you all who came out here. So I don't have any disclosures relevant to this talk. So we're going to spend the next little while talking about, first I'll introduce you to the autonomic nervous system and what it is, so you'll have a little background as to why and the terminology and why I might talk about it in relationship to headache. And then we'll talk about some case examples of how headache and autonomic nervous system can overlap and how the treatment plans for each can overlap as well. So the autonomic nervous system is the part of our neurologic system that helps balance our interactions with the environment. So it's helping our bodies to achieve a status of what we call homeostasis, which is balance between various different forces within the nervous system: metabolism, energy, electrolytes, etc., all coming together to be balanced by various chemical and nervous controls. And the autonomic nervous system is the neural control involved in that. It's globally broken down and is actually part of the traditional nervous system we talk about, broken down as the central nervous system, which is the brain and spinal cord, and the peripheral nervous system, which is the nerves outside of the spinal cord in our hands and our feet. And traditionally is talked about as a peripheral part of the nervous system, broken off separately from the somatic nervous system, which is where our motor, our movement, and our sensory, our sensations, part of our nervous system is controlled. But it's also not included here under the central nervous system, where there are important regions, specifically in the hypothalamus and the brainstem, that help control this balance of the nervous system's reaction to the environment. So one other way to think about it is an integrative network, sort of part of our processor in our brain that helps balance how we tell our heart to go faster or slower, how we tell our blood vessels to squeeze or relax, how we tell our bladder to work or our digestive systems to work. And it interacts with important other physiologic systems, metabolic systems, including renin-angiotensin, which is where the kidneys work to keep our salt balanced, our blood sugar balance, pH balance, our reproductive behaviors and our hormones linked to that, our motor behaviors, meaning how active or not active we are in certain environments, and then endocrine, our thyroid and our adrenal glands. Again, all of these systems interact with this part of our nervous system and get feedback to and from. Generally speaking, the autonomic nervous system can be broken down into two key sets of function that help, I think, to conceptualize what the role of this part of our nervous system is. And so there's one section that we call the sympathetic nervous system, which is best associated with fight or flight behaviors. So it's the part of our nervous system that helps us activate what needs to be activated to run away from a bear or a threat as we evolved as humans in society. This is now replaced a lot by stressors in our environment that are not always life-threatening. And this serves to activate our blood vessels, our heart to beat faster, our blood vessels squeeze, our internal organs either activate or deactivate depending on if they're useful for helping us run away from something life-threatening. It helps control our sweat and alert us overall. In contrast, and to balance this part of the autonomic nervous system, is a side we call the parasympathetic, in contrast to sympathetic, which is what the fight or flight was. And this is our rest or digest section. This is how we counterbalance that urge to run and survive. This is when we actually regenerate, rejuvenate, digest our food, make urine, our heart rests, our blood vessels rest, relatively speaking, in this state. And it's a little arbitrary to split these up strictly, because they really are in balance all of the time. There's a little bit of action from both sides of this nervous system present all of the time to keep us in balance. And these parts of our nervous system are coordinated to not just respond to activity like exercise and stress, as I just mentioned, but also emotional stimuli and environmental stimuli that may trigger us to engage in certain behaviors, such as a smell that brings on a relaxing association that then can link to our parasympathetic rest and digest signals and help our heart rate to slow down, our breathing to slow down, and engage relaxation. So I want to talk a little bit briefly, without getting too technical, about how we can measure this part of the nervous system. So we're very familiar with brain MRIs and CT scans to look at pictures of the brain. We use nerve conduction studies to look at function of peripheral nerves, and there's an analogous set of tests to test the peripheral functions of the autonomic nerves. And this is set up in a diagnostic laboratory here in this building, where we have a tilt table here, pictured here, and then some fancy blood pressure apparatus that helps us test blood pressure and heart rate from beat to beat to beat. So it's a very nice signal of exactly what's happening in terms of those signals, and we're able to measure sweat as well. And this protocol comes together in a way that allows us to interpret whether there's a neurologic cause for autonomic dysfunction occurring. And it has what we would call high sensitivity and specificity for neurologic disorders of the autonomic nervous system. So autonomic nervous system testing in our laboratory is a standardized battery that includes 4 basic tests. One is of sweat testing. This is a what we call stimulus-induced or reflex-based test, where we make you sweat into these little electrodes right here. They're tied onto the skin with straps, and we infuse a little chemical through the skin that causes you to sweat, and we're able to measure the volumes of the sweat within those little capsules. And that's a reflex-based sweating. So it's not stress-based sweating or heat-based sweating in this environment, but it's reflex-induced in the laboratory. It tells us the sweat glands and the nerves are intact or not intact. We measure that parasympathetic side of the nervous system, which is also termed cardiovagal, in 2 different ways. We measure heart rate and blood pressure changes to a few different reflexes. One is heart rate variability to deep breathing. So that's pictured here. The person breathes in slowly at a paced rate, and their heart rate actually goes up and down with their breathing. And that's a normal reflex where our breathing is linked to our heart rhythms through this part of our nervous system. We also can measure this heart rate variability to another reflex called the Valsalva maneuver. Valsalva is what we all do when we lift something heavily, when we bear down, and sometimes people faint with a Valsalva maneuver, and so it's useful to measure what happens with blood pressure and heart rate during this type of maneuver. So here we have somebody producing a maneuver, and this is their blood pressure. Their blood pressure goes up and then down and then up again in a predictable fashion, and their heart rate does the same thing. It goes up and then down again, and we can measure those amounts of change. We measure the sympathetic side of the nervous system, which is also called cardiovascular adrenergic, in 2 ways as well. So we can look again at the Valsalva maneuver blood pressure changes, and here's a simplified. This is actually this zigzaggy looking line, simplified. Again, up, down during the course of that maneuver, and we can tell if that reflex is intact and normal versus something's amiss with the nerves that might make this person susceptible to fainting. And we have a tilt table test, and here is a blood pressure trace and a heart rate trace that occurs during a tilt table, and we'll show a few more examples of this in a moment relevant to, again, how this part of the nervous system might be relevant to headache disorders. So as you might imagine, by all the types of activities that I just described this part of the nervous system being involved in, we often need specialists outside of neurology to help thoroughly evaluate symptoms that could be linked to this part of the nervous system. So we've talked a lot about heart rate and blood pressure, so we often also have cardiologists involved to help us evaluate the heart's rhythm as well as the heart's function. We also have GI involved because the gut actually has its very own nervous system that can be dysfunctional separately from the autonomic nervous system, or again, the gut can be affected by disorders that have nothing to do with the nervous system at all. And so it's important also, if somebody's having GI symptoms, to evaluate those directly. We often also have a sleep study or sleep specialists get involved because sleep is very frequently disordered in individuals with autonomic trouble, as well as headache disorders, specifically insomnia, but sometimes fatigue and sleeping too much during the day. Endocrine, again, I mentioned earlier blood sugar and renin and angiotensin and adrenal glands all overlapping with endocrine nervous system, the endocrine realm that could be independent of nervous system dysfunction. And then finally, rheumatology. Disorders such as lupus, where there's a systemic inflammatory condition where inflammation is happening all over the body, can sometimes also cause inflammation in this part of the nervous system, and trying to clarify a rheumatologic diagnosis and treatment plan can be key. So let's talk a little bit more about what types of symptoms autonomic dysfunction can be associated with. So there's an important term here called orthostatic intolerance, and this means whenever somebody is standing up upright, they get some type of symptoms, and usually it's a few different symptoms, and those occur every time they're standing up for a prolonged period of time. And when they lay down, that set of symptoms goes away. Those symptoms can vary from dizziness to fatigue to headache, to visual loss, to sensation changes, and importantly can be associated with changes in the heart rate and blood pressure that I've been talking about, again controlled by this part of the nervous system. And when this is present, oftentimes individuals with these types of symptoms are at higher risk for fainting, or something we'll call syncope in the coming slides. So the general underlying cause of the symptoms associated with orthostatic intolerance is generally due to a few categories of things. So lightheadedness, fainting, sometimes difficulty concentrating, headaches that can come in, dimming or blurring of vision, are thought to be related to cerebral underperfusion. That is a fancy term saying that the blood is not getting to the head adequately. And that is what's thought to be linked to some of these symptoms during the presence of orthostatic intolerance in these individuals. Now also we get, sometimes we get palpitations or thumping sensation in the chest, tremulousness, shortness of breath, and sweating increases or decreases that are sort of abrupt during the course of standing. And these are thought to be related to activation of that sympathetic side of our nervous system. Activation because the body is under stress while in the upright posture. And then there are some other symptoms that are maybe a little bit more hard to place. Fatigue, weakness, nausea and abdominal pain can occur when individuals are standing, and those don't have as clear of an underlying mechanism to explain. Now, I mentioned that fainting can be one of the common outcomes, and so I want to talk about a case that sort of ties these ideas together. So this is a 40-year-old woman who has a history of chronic migraine, and she's also had difficulty with exercise, increasingly becoming intolerant to routine exercise over the last several years. And she's severely fatigued, and she says even if she exercises briefly, she gets payback fatigue, meaning her fatigue gets even worse after exercise. She doesn't feel better. She also has sleep disruption, really poor quality, doesn't feel rested when she gets up, has a hard time getting to sleep. She doesn't tolerate differences in heat or cold temperature environments, and is having trouble with short-term memory and word finding. So she actually comes in to my office asking if she could have a dysautonomia to explain some of these symptoms. She'll see some of her symptoms overlap with what we've been talking about. So in an evaluation here, one of the first things we want to think about is looking at those blood pressure and heart rate responses and see if we can understand what's happening. So she has her blood pressure done lying down, sitting up, and standing up. And we're looking for significant changes between the blood pressure in those positions. One key thing we're looking for when we do this is orthostatic hypotension, which is a term we describe when blood pressure specifically drops. And it drops a number of 20/10. So you can look here at her lying and look down at her standing, and you don't see that big of a drop, certainly not a drop over 20/10. And you can sometimes see an increase in heart rate. So in this individual, we can't explain her symptoms when she's standing up or exercising by a drop in her blood pressure. So we might go after another cause. And so here's where we could use the tilt table evaluation. So in this case, where here she's lying flat, here's blood pressure, systolic and the diastolic, that top and bottom number, and her heart rate. And when she tilts up, you can see how her heart rate shoots up and actually oscillates significantly, and then the blood pressure starts to oscillate as well. You can see how her blood pressure sort of drifts with time, and by the time she's been on the tilt table for several minutes, her blood pressure actually has dropped enough to be considered as orthostatic hypotension. Now, what's supposed to happen when we stand up? If that's not what's supposed to happen, what is supposed to happen? Well, when we stand, about a liter of our blood pools in where we would call dependent areas. So our legs, mostly. Our pelvis also has cavities to gather some of our blood. And importantly, when it's in these dependent areas, it's not in our upper body or our head. This is where the symptoms of lightheadedness, headache, visual changes occur. To compensate, the normal individual is going to release adrenaline in order to try to stabilize that system. And that's part of that fight or flight adaptation that we use in our everyday life to go from sitting to standing, hundreds of times a day. And then you can see here what a normal response might look like. Generally speaking, blood pressure stays pretty stable from minute to minute. There are small oscillations, but with good recovery, where it's pretty much striking the same blood pressure consistently over time. And you can see the contrast between the woman who's complaining of feeling severe fatigue, fogginess in her head, and a headache when she's upright in the blood pressure and heart rate changes. So again, how is this linking to migraine? Well, interestingly, this pattern can be seen in an individual with chronic migraine just as much as it can be seen in individuals who come in complaining of fatigue and dizziness separate. Also linking these is the presence of dizziness. Up to half of individuals with chronic migraine have dizziness with their headaches at some point through the course of their headache problem, whether it's during a headache attack or in between on a daily basis. Up to 50% experience some type of dizziness. Now, there are different types of dizziness. One, termed vertigo, is a spinning type sensation that is thought to be a different type of mechanism than this lightheaded sensation that we're talking about here when we're referring to orthostatic intolerance. And this chicken or egg phenomenon in terms of why does somebody with chronic migraine look like this is difficult. Is this because of the migraine, or is this because this person is suffering from migraines every day and becomes, for example, dehydrated, deconditioned, or something non-specific, not related to the headache that could cause blood pressure and heart rate to become unstable? What we do know, though, is that if you treat the blood pressure and heart rate instability directly, you can actually benefit the headaches. So in this case, focusing on hydration, exercise are key things that can intervene in the blood pressure and heart rate instability, will help those headaches. And we'll talk a lot more about those in the coming few slides. So what should we do in cases of orthostatic intolerance, dizziness, lightheaded, brain fog, and headache that occur primarily with standing and are relieved with lying down? This can be very debilitating. So one of the top #1 things is to increase fluids. This is something we always talk about. Everybody is thinking they need to drink more water on a daily basis. This is taking it there and pushing it beyond that. These are significant amounts of hydration needed whenever blood pressure and heart rate become that unstable. So if the average recommendation is something like 1 to 2 liters a day, we're talking 2 to 4 for individuals with these types of symptoms. We also need electrolytes to complement the fluids and hold the fluid in our blood vessels so that it's inside our blood vessels have something to squeeze on and help stabilize the system. Salt is a major electrolyte in our diet, and generally speaking, most of us get enough. If somebody has orthostatic intolerance, they may need a little bit more than the average person. As long as they don't have high blood pressure problems, this is okay. If high blood pressure is an issue, we have alternate electrolytes to focus on. Potassium and magnesium are 2 useful electrolytes. Potassium, magnesium, and calcium are found in smart water, for example, electrolytes that are not sodium containing. Now, another key element of this is reducing stress. I mentioned this surge of adrenaline that can occur to compensate for standing up. Sometimes a surge of adrenaline can get overwhelming and contribute to worsening tachycardia, worsening fatigue, worsening headache. And so combating stress and trying to decrease environmental triggers of adrenaline surges is actually really critical on a day-to-day, long-term basis. In this scenario. And getting more sleep. We always know we need more sleep to be well, but when sleep is disrupted in the ways I described, having insomnia, having frequent awakenings, or not having restful sleep, then it sometimes needs to be medically addressed by a physician who can help try to dissect what's happening there and get an appropriate sleep aid on board, whether it's a medication or a behavioral intervention. And having your doctor review medications that could be making blood pressure or heart rate instability worse, screening for anemia or iron deficiency, which can also make blood pressure and heart rate instability, fatigue, and lightheadedness worse, and then blood sugar problems. These are things that we don't think of routinely as linked to the nervous system, but if present can make it a lot harder to treat the neurologic problems, specifically, again, the headache, the dizziness, the fatigue. What can we avoid in these circumstances? So excessive alcohol actually makes our system widen the blood vessels all over the body, and that pooling that I talked about when standing in our legs and our pelvis gets worse. So you can make these symptoms a lot worse with excessive alcohol. Similarly, if you're dehydrated, you don't have enough fluid in the tank to squeeze and to get your blood pressure stable, can cause the similar problem. Getting overheated and excessively sweating can lead to dehydration, can lead to vasodilation, or again, widening of the blood vessels, and make symptoms worse. And eating large meals leads to blood vessel expansion in our gut that then again diverts blood away from our heads, making these symptoms worse. These are all things that can be modified or sort of paid attention to in the environment that might help reduce symptom burden. Another mistake is sometimes people get their blood pressure and heart rate issues identified and are given medications without anything we just talked about, the fluids, the salt, the avoiding large meals. All of those things are key. If you start the medications alone, you will not get the same benefit because these medications rely on sufficient fluids and salt to work. And additionally, the medications must be combined not just with fluids and salt, but usually compression garment. And this picture here is a little bit misleading because compression stockings up to the knee usually don't do the trick. You usually need compression garments either on the thigh or abdomen. So skipping the sock and going straight to compression shorts is actually usually a more effective compression garment to combine again with fluid, salt, and maybe medications. So let's talk about another case example. So this is a young man who has a 1-year history of unexplained symptoms. He got the stomach flu about a year ago. During this time, had pretty routine stomach pain, nausea, vomiting, severe fatigue, just like anybody who gets the stomach flu. But interestingly, he didn't really recover fully after this. His stomach flu acute illness passed, but he continued to have chronic daily nausea and vomiting and came in these spasms. And when they would occur, the spasm of nausea and vomiting would be accompanied by a headache. He'd be lightheaded as well, and he had fainted several times. So let's talk about fainting. Fainting is quite common across the general population, across all age groups. It is more common, up to twice as common in women than men. And most of it, about 1/5 here, is thought to be benign, and it's reflex-mediated syncope, which is often called vasovagal syncope, and it is, while very annoying, not thought to be caused by a problem with the nervous system or a problem with the heart. And that's generally the most common answer. The most worrisome answer is if the heart is causing the fainting. And this increases with age and cardiovascular risk factors and is the highest risk of death or injury. So it's really the first place most people go when they have issues with fainting is a cardiologist's office. And then there's a number of other potential issues, and you see down here neurologic, which is the focus of what we're talking about. So syncope and migraine are actually linked. The population that syncope occurs frequently in is a similar population that migraine occurs frequently in. These are the young women, and so I listed here odds ratios, which are basically a statistical way of saying how two conditions are related, and if you have one, how likely are you to have the other. But either way, syncope is related to migraine, chronic fatigue syndrome, the presence of a slow-moving gut or gastroparesis, interstitial cystitis, which is a bladder problem, and POTS syndrome or postural tachycardic syndrome. And we'll talk a little bit more about that in the coming slides. The lifetime prevalence of fainting is 41% in those with migraine, which is far higher than the general population. And up to 1/3 of those who faint have migraine-like headache either before or after their fainting episode. And this has been termed syncopal migraine in the past. It's a little controversial of a topic because not all headache doctors believe this to be a migraine-linked thing. And about 40% will have a non-specific headache. Either way, headache accompanies syncope quite frequently, and again is a target for directed treatment, not just focusing on the syncope and going to the cardiologist's office, but thinking about the headache and addressing the headache itself as well, if these are two recurring problems. And in this group with the syncopal migraine, interestingly, anti-migraine medications actually reduced their syncopal attacks or their fainting attacks, just like it reduced their headache attacks. So we do think this is linked in some individuals. So going back to our young man who had the stomach flu and then had a few episodes of fainting and persistent nausea. So we did the same thing with him. We had him lie down and then we had him stand up. And in this case, we see a little dip in his blood pressure when he stands. But interestingly, we see his heart rate is pretty low when he's lying and it goes up pretty dramatically when he stands up. And this is a hint towards something called postural tachycardic syndrome, and I introduced that a few slides ago. This is defined specifically as a heart rate increase over 30 beats per minute when somebody is standing, and then it reproduces their symptoms of orthostatic intolerance, as we introduced in the early slides. And this has to persist at 5 to 10 minutes of being upright. And this is specifically, by definition, in the absence of orthostatic hypotension, was that first thing we talked about where blood pressure drops when somebody stands. Specifically, blood pressure stays steady, as you can see here in the red lines. This is systolic and diastolic, again, staying nice and steady. But you see the heart rate in green shoot up and stay up. This is a sustained increase, and this is postural tachycardia. Postural tachycardia syndrome is a disorder that we call idiopathic because we don't really know the underlying cause in most individuals. We know that it is chronic and can be recurrent as well as disabling and tends to need to be present over 6 months before a diagnosis can be confirmed. And generally speaking, we think this is a final common pathway for multiple overlapping pathophysiologies, so potentially neurologic causes as well as other non-neurologic causes can end up in this exact manifestation. And the two key things being here is that in some individuals there's the presence of a neuropathy, and again, as I mentioned before, this increase in sympathetic activation that causes excessive excitation and leading to a lot of the symptoms present, the palpitations that we reviewed on a slide ago. This slide's not to be overwhelming. This is how complex it really gets when we're dissecting exactly what all is contributing to POTS syndrome. But I wanted to draw your attention down here to the non-orthostatic symptoms, and right here, headache is smack dab there. Key to this being linked to this combination of the venous pooling, the sympathetic activation, and then these symptoms. We've got GI symptoms here. We have anxiety and behavioral amplifications happen once you get these types of symptoms, and you start to react to them and you get more anxious because of your symptoms, and that actually escalates the adrenaline surges that come from the symptoms in the first place and can really create a spiral of ongoing symptoms. So who gets this? Well, it's usually young individuals, mostly under 40. Anybody over the age of 40 with concern for this diagnosis, I encourage to look for other explanations. This is 5 to 1 women to men in terms of more frequent in women, and often comes on after a viral infection like it did in our case example. Can come out after a surgery or a concussion, or can just come out of the blue for no apparent reason. Symptoms generally get worse, similar, just like orthostatic intolerance, with heat after eating big meals, prolonged standing, and dehydration. Introducing here something that is also important in orthostatic intolerance, but is a core treatment for postural tachycardic syndrome, is a graduated exercise program. This is targeted at increasing muscle tone and promoting return of that blood vessel pooling that I talked about to get that back up into the head. We do that by strengthening our muscles and encouraging cardiovascular conditioning. Oftentimes when somebody is intolerant to being upright, it's really hard to exercise. You can't just go out and run or even walk sometimes for exercise. And so starting with a recumbent activity like swimming, recumbent bike, to gently engage aerobic conditioning may be the only way to start, beginning with 5 to 10 minute intervals and building up slowly till those intervals add up to 30 to 40 minutes each day. Weight training, focusing on core and lower extremity strengthening, muscle strengthening, can help again getting the blood pooling out of our pelvis and our legs, and help use our muscles to pump blood into the proper places. And so strengthening in those muscles can be really effective. And there are some maneuvers that one can strike a pose here, this guy. Each one of these maneuvers are activating the same muscles that I'm recommending strengthening here, and each result in increasing blood pressure temporarily while he's in that position to help stabilize blood pressure. And this is very useful for preventing fainting if somebody's been standing up for a long time or is becoming near faint with their symptoms. And then lastly, I already emphasized this, the role of compression garments. They can be sort of a temporary assist while you're strengthening these muscles. They squeeze in those same places, again, abs and thighs, not just calves. So one last case example before I take questions. So this young woman is a semi-pro football player, has had 6 months of severe headaches, dizziness, near fainting, and sleep disruption. She's had to drop out of school. She had a series of 3 concussions that occurred at the beginning of all of this, and unfortunately didn't get enough rest between to fully recover, meaning she still had symptoms when she got the next one, and then actually got a next one. And her current symptoms, this headache, dizziness, and feeling of fainting, occurs every single time she tries to exercise now. She has a normal neurologic evaluation. She has a brain MRI to make sure those concussions didn't result in any brain injury, and ultimately winds up getting this battery of autonomic testing. So I'll show you what her tilt table looks like. So you remember, so we have these baseline lines here. This red is the blood pressure combined into one line, and the green is the heart rate. And you can see, you can see how the blood pressure stays fairly stable. There's actually a dip initially with a good recovery, but you see how the heart rate shoots up. So this is at this stage 6 months later. She, if you didn't know her story, would look on her tilt table just like that postural tachycardic syndrome, except her story is very different. She got bonked on the head a few times and developed headaches, and that was her main symptom. This person also happened to be involved in our headache study here and had testing before she got her concussions. So she has baseline testing. This is what she looked like before she got her concussion. So see how steady her heart rate and her blood pressure actually compensates in a very normal way when she was turned upright, which is just a tiny little increase. And then it goes back to normal when she goes back down. She came in fairly currently after, I can't remember which of the 3 concussions, and you can see that some of those changes were present pretty early on, though not as bad as this. You can see some increase in her blood pressure instability here, a mild increase in her heart rate, but at this point it was equivocal in terms of whether it was going to be abnormal or not. So what she's dealing with is a combination of 2, I think, key things. Post-concussive syndrome, which is persistence of symptoms that are thought to be related to the concussion. So not just the headache, but some of the mood changes and irritability, sleep disruption, and balance disruption that come with a concussion and define it as a clinical event. And then headache. And headache is by far the most common symptom across all concussions, and gratefully resolves in most individuals receiving a concussion. Headaches that come with a concussion can be very variable. Probably a majority seem to manifest as a tension-like headache. Often those individuals had a whiplash type of maneuver when they received their concussion. Up to half, though, have a migraine-like pattern, in terms of a focus of area of where the pain is, a throbbing-like sensation, light sensitivity, nausea, vomiting, just like a migraine. And then there are more non-specific or mixed types, and then there are rare variants. Some cluster headache and trigeminal neuralgia have been associated with post-concussive headaches as well. So as I mentioned, headache is the most common symptom to occur after head injury, and this is 90% or more. Acutely, we tend to call that headache a post-concussive headache, and we expect it to go away. If within weeks it's still there, then we're thinking this is post-concussive syndrome, and it's persisting, often accompanied by some of those other symptoms like our patient had. And then chronically, if it's present beyond months, it sort of makes a transition maybe to persistent post-concussive syndrome, but predominantly to the diagnosis of post-traumatic headache. What we do for post-traumatic headache is not unlike what we would do for the type of headache it's manifesting as. So if it's a tension-type headache, we address it like tension headaches. If it's a migraine-like headache, we'd address it like migraine, and specifically use migraine-targeted medications like triptans. And if it's a cluster, a headache, we approach it that way. Preventative medications used for migraine or tension headache or cluster headache can be useful in those with post-traumatic headache, though unfortunately not as useful as they are in those without the head injury. So we only have 30 to maybe 50% of a response in these individuals. Sometimes Botox or trigger point nerve blocks, just like we use for migraine and chronic migraine, can be helpful, but again, sort of a lower yield treatment. And it seems like there's something else going on beyond the headache syndrome in these individuals. So we add a few things to their treatment plan, and these will sound very familiar at this stage. So avoiding recurrent concussion is critical. I highlighted that this individual didn't have full recovery between her concussions, and the sort of cumulative effect of multiple concussions likely resulted in a worse outcome for her in terms of still having symptoms at 6 months. Addressing the stress and reducing not just mental stress, but physiologic stress. So staring at a screen, a computer, a TV, or a phone all day is actually quite taxing on our brain processing, our eyes, our postures. And so trying to take out some of those physical stressors as well. As these symptoms persist, often medical intervention is needed to ensure sleep is occurring. I mentioned having behavioral strategies to target sleep as well. Mood disruptions, as I mentioned, comes early on with concussion. So sometimes irritability or trouble easy anger comes out in an early concussion and doesn't really go away, and sometimes needs addressed and evolves into mood symptoms that may need a therapeutic intervention. And then, as I shouldn't have to say here too many more times, treating those headaches will ultimately affect that whole symptom set in the post-traumatic headache and post-concussive syndrome. And I mentioned behavioral therapy, so for sleep as well as for the cycle of suffering with this daily pain, trying to come up with a way to cope with the negative emotions, avoid withdrawing and coping in a way that's not productive and healthy, and trying to minimize the distress that's coming from not being able to engage in the life that occurred before the onset of these things. Intervention specifically focusing on behavioral therapy approaches are key here. We've talked a lot about physical activity and exercise and the role of conditioning, and that comes in here with post-concussive syndrome and post-traumatic headache in a very similar way, using these recumbent exercises, focusing on strengthening of the core and abdomen and upper legs, and then sometimes also balance retraining is needed with some types of concussions, focusing on electrolytes and fluids as we did before as well. So I wanted to leave a few minutes for questions, if anyone had any, and also if you or anyone you know is interested in participating in the headache research. We do focus on post-traumatic headache, autonomic dysfunction, and headache and migraine, and we have a little packet out on the table that's our study group. So with that, any? Stunned. Yeah. No, thank you for being here, everyone. I'll try to linger a little bit if you have questions afterwards.